Okay. Today's webinar is brought to you by MTM Health, who is a longtime MHPA partner and longtime supporter of our health plan members. We thank them for organizing today's presentation, From Access to Outcomes, Transforming Maternal and Infant Health. With that, I'm excited to turn things over to Julie.
All right, thank you so much, Patrick. Appreciate it. And thank you all for joining us today as we walk through some of the ongoing issues we're seeing around maternal health. As Patrick mentioned a minute ago, please feel free to put your questions in the chat, and we'll save a few minutes at the end of the presentation to try and get through those. So today, what are we going to cover? We're going to talk about some key components on maternal health and what is necessary to ensure a healthy outcome for both the mom and the baby, and why maternal and infant health matters. We're going to talk about the state of maternal and infant health in the United States today, and what is needed to remove barriers, and specifically what MTM is doing to put the solutions in place. We're going to review mobile integrated health and why it's necessary to take a patient-centric approach, and then we're going to leave you with a couple key points that we'd like you to remember from today's session. So today, I'm just going to kind of go through our panelists. I'm Julie Kulowick. I'm Vice President of Business Development here at MTM. I started my career as a registered nurse in oncology and bone marrow transplant for about 8 years. After that, I spent several years on the PBM side of healthcare, working closely with providers and managed care organizations. So having worked closely with patients, physicians, and clients directly, I've really seen firsthand the need to work together across the healthcare spectrum for all members that they have adequate access to the care they need. You're also going to be hearing from Tracy Kelmar. She's Vice President of our National Managed Care Solutions and Medicare. And Tracy brings decades of experience in emergency medical services to her role. She's a former paramedic, and she is our current operations leader. So she has firsthand insight into the critical role of mobile integrated health and improving patient outcomes. And her expertise in innovative healthcare solutions has allowed her to develop strategic partnerships that really enhance care coordination and access to these vulnerable populations. And then lastly is Colleen Schlee. She's our Vice President of Managed Care Solutions. And Colleen's extensive experience in the healthcare industry and working with large healthcare systems and managed care organizations. And Colleen joined us in 2019, and she's played a key role in enhancing the provider relations and implementing innovative solutions in our markets nationwide. She's a licensed paramedic in Florida for over 20 years, and she was a first responder as well. So she really brings valuable insight into mobile integrated health programs and maternal care. So just before we dig into maternal health, just a little bit about what MTM is, and I wanted to just give you a little bit of where we came from. So Peg and Lynn Griswold founded MTM back in 1995 when they realized the difficulty that health plans and government organizations faced when they were arranging transportation for Medicaid and Medicare members. And then in 2005, their daughter, Elena Macia, took over as the CEO, and she's been at the helm ever since. So moving into our 30th year this year, MTM has really set the industry standards, and we're now the largest privately owned non-emergency medical transportation, known as NEMT, broker in the nation. We're a woman-owned business, and we're privately held. So being privately held, we kind of avoid all those noise and distractions that come with being a publicly traded company. But we're large enough to have the vast access of resources, yet still answering directly to our clients and members. And during the past 30 years, we've provided services for city, county, and state governmental agencies, and also other organizations serving transportation to our disadvantaged, special needs, aging, and those individuals that are covered by Medicaid and Medicare. We provide just around 35 million trips in all 50 states and Puerto Rico and DC, and we serve about 24 million members each year. We also handle about 13.5 million calls through our customer service operations. We're very big into technology-driven company. We have strong investments, which really have allowed us to overcome many of the obstacles that we see in the transportation part of the healthcare industry. And we were founded to deliver these NEMT services, but over the past few years, we've expanded our operations to offer home and community-based services as well. So just looking at it from today and what we want to do, and why does maternal and infant health matter so much? We know it's critical for Medicaid families. We'll talk about this a little bit more. We know that transportation challenges lead to missed prenatal visits, the delayed postpartum care, and the limited supports of services that really can put those mothers and babies at risk. We need to build trust and empowerment with those new moms. We have to ensure solutions that would have timely care and foster healthy beginnings for these babies, which produce better outcomes. So today, what we want to do is explore what we're doing in NEMT from the innovation perspective. We're going to talk a little bit about the mobile integrated health integration, some success stories, and how we're aligning with the TMaH model, the Transforming Maternal Health model that CMS rolled out in January this past year, and how that impacts in maternal and infant health outcomes. So let's go ahead and get a lay of the land and just dig a little bit deeper into what we're seeing in the maternal health landscape today. So if you look at this, women in the United States are more likely to die from complications related to pregnancy and childbirth than their peers in other high-income countries. Like, let that sink in. That's a really scary thought and a lot to think about when we look at our healthcare in the United States today. This topic is so close to my heart, not only as a nurse, but I experienced it firsthand when my sister almost died when she gave birth to her third child. She ended up immediately in ICU. She needed emergency surgery, and she had a really long recovery. And this all happened in a major metropolitan city. And I know that not every maternal complication has great results like hers did, but that's really why we need such a focused effort to improve our outcomes. If you look at the maternal mortality crisis, the mortality rate was right around 22 deaths per 100,000 live births in 2022. Going to 2024, that rate decreased to a little over 18 deaths per 100,000 births. So even though we've had that little bit of decline in the last 2 years, the United States still continues to see one of the highest maternal mortality rates among these high-income countries that I just mentioned. Additionally, if you look at 2024, Black non-Hispanic mothers face mortality rates averaging around 48 deaths per 100,000 live births, which is over 3 times higher than white mothers, which just is not acceptable. We also know that the potential Medicaid cuts could jeopardize coverage for 24 million women, which is going to increase risk. We know rural areas are most likely going to be impacted as well, as these areas today see 2 times higher mortality rates than the urban areas do. If we switch it a little bit and look at the infant mortality challenges we're seeing, the US infant mortality rate was just about 5.5 deaths per 1,000 lives in 2024. And looking at it, we know there's so many disparities in infant mortality. Infant mortality, it's higher among Medicaid families than in privately insured. It's higher in southern states like Mississippi, which saw an average of just under 10 deaths per 1,000 lives in 2024. And as I mentioned a minute ago, it's higher in rural areas. Preterm infants in rural counties face greater mortality risks than their urban counterparts. And what are the key drivers of this? We know it's preterm birth. We know it's low birth weight, which is often associated with preterm birth, and access issues. So when we look at it from a macro level, as I just mentioned, we know that transportation plays a major role. 25% of the patients indicate that lack of transportation is a primary reason for missing or rescheduling their appointments. Rural communities face longer travel distances and limited providers, and that again leads to delayed prenatal care. And over half of rural counties lack obstetric services, which these new moms need desperately. So the consequence of this all leads to an increased risk of prenatal appointments, delayed care, and higher maternal and infant health complications. So now that you know what we're dealing with as a country, what are we doing about it? I'm going to go ahead and hand it over to Tracy to discuss how MTM removes the barriers we often see associated with the maternal health. So Tracy?
Thank you, Julie. So what is MTM Health doing about this? Why does a tailored transportation solution make a difference to our pregnant and new moms? First, it offers flexibility and convenience. The ability to schedule transportation when the need arises with the same day or next day scheduling options provide a level of convenience and access that is not present with other type of programs. Additionally, it offers safety and comfort. Our specially trained drivers and our care coordinators work with these pregnant and new moms to set up their transportation rides to meet their needs. Most important, it offers access to care. Transportation, getting members to their appointments, to their medical appointments, and to other SDOH needs is a high priority, and you'll see how MTM Health does it successfully. So what do we have to accomplish these things? First, we have our option. Our VEO Ride is MTM Health proprietary network of rideshare drivers. It provides reliable access to medical appointments. It can provide door-to-door service if needed. Additionally, the technology is awesome. They can do ride tracking, notifications, mobile bookings. Additionally, caregivers can book and monitor rides on behalf of members. How does it work? Trips are pushed to VEO Ride driver app for real-time acceptance, similar to Lyft and Uber. It features 100% GPS tracking. The driver advantages, all our VEO Ride drivers use the VEO Ride app. These drivers are credentialed, they're tech-enabled, they're healthcare trained. The average age of our driver on VEO Ride is 54 versus 28 for Lyft and Uber. Our average VEO Ride driver tenure is eight times longer than traditional rideshare services. What does that mean? It benefits our members, providing reliable, safe transportation that's tailored to maternal health. We have a second option, and that is our Lyft Flex integration option. It provides a seamless experience while Lyft is integrated with MTM's health scheduling platform. MTM Health sets a trip request with Lyft. Lyft sends the member a text to request a ride when they are ready, and then the member books an on-demand ride via that texted link. Lyft Flex also offers a safety enhancement called Women Plus Connect option. This option matches women and non-binary members with similar drivers, offering an additional layer of comfort and ease. We have been working to assign more and more of our new and expectant mothers to Lyft Flex as their mode of transportation. Approximately 83% of our Lyft Flex trips for maternal health purposes are short notice trips. We believe this is a great indicator of the need for a flexible transportation solution for maternal health members. 100% of these trips have been successfully completed with no service ride failures. And then wanted to talk about our pilot programs. So we have a pilot program in Ohio. It's targeting our pregnant, postpartum, and infants under 1 year of age to remove their transportation barriers. The pilot will cover 100 trips for that population. It's going to feature a dedicated concierge line with trained care coordinators for trip coordination and scheduling. This trip coordination and scheduling will not only be available to the member, but it will also be available to the healthcare providers that are supporting these members. The on-demand availability requires no day's notice or advanced scheduling notice for medical appointments. It's going to feature specially trained drivers for wait and return service during appointments. This means there will be no need for a new mom to reinstall car seats or uninstall car seats and carry them into appointments with them. It allows them to leave those car seats safely installed in that vehicle until they are completed with their appointment and returned home. In addition, we will do post-trip surveys for these members, providing them the opportunity to give feedback on their trip, how it went, any concerns or any barriers, and any positive items they can share during that survey. It will also allow, during that survey, allow them to schedule any future trips that may be needed. The goal of this pilot is to build trust and ensure consistent care. The success of this pilot will be primarily based on member satisfaction. We also have a pilot program that we started in September. This pilot is with our Missouri Boot Hill Regional Consortium. I'm going to say that several times, so apologize if I stumble over it. It's kind of a mouthful. But in Missouri, MTM Health partnered with the Missouri Boot Hill Regional Consortium for a pilot program with the goal of supporting families in that Missouri Boot Hill region to reduce infant mortality. These rural communities in this region encounter unique barriers, including limited medical provider availability and significant travel distances. MTM Health currently manages the non-emergency medical transportation services for Missouri Health Net Medicaid members in those local counties. The Missouri Boot Hill Regional Consortium also works with many pregnant and new mothers in this region to transport them and their infants to essential medical appointments. In addition to this, the Missouri Boot Hill Regional Consortium offers support services related to domestic violence and other SDOH challenges. MTM Health and the Missouri Boot Hill Regional Consortium collaboration launched in mid-September and is intended to offer a more seamless transportation experience for eligible members, bridging care gaps in access and improving equity in our rural communities. With that being said, I'm going to turn it over to Colleen to talk about our mobile integrated health. Colleen?
Thanks, Tracy. Yeah, thanks, Tracy. Yeah, I get to talk about mobile integrated health, which is one of my favorite topics in healthcare. So I'm always happy when they give me this particular section to talk about. So mobile integrated health, for those of you that aren't familiar, is a patient-centered care delivery model that brings care to the patients by coordinating resources among EMS, local healthcare providers, community-based organizations, virtual care platforms, and the health plan. So this proactive coordination enhances outcomes by bringing care into comfortable settings such as the patient's home. MIH aims to reduce hospital readmissions, especially 30-day readmissions, overutilization of emergency medical services, your 911 systems, and to provide more proactive preventative care and increase access in underserved rural and frontier areas. So think your healthcare deserts. MIH programs are designed to increase availability and accessibility of care by navigating patients to the right care, the right place, at the right time to save community resources and manage the cost of care. So when you think about it within the context of this maternal health care program, we're talking about community health workers that can provide screenings, postpartum care, address social needs, as well as a clinical aspect that we'll talk about here a little bit farther in. So at MTM, our plug and play maternal and infant health program utilizes a development of a whole person approach to pregnancy, childbirth, postpartum care, addresses the physical, mental health, and social needs that are often experienced during pregnancy. So the physical health, we're talking about prenatal screenings, labor delivery care, postpartum care. Mental health includes postpartum support, anxiety and depression management, early identification of patient change, especially around issues of postpartum depression or psychosis. And social determinants would include community-based support, culturally sensitive care, aligning patients and members with additional supports they may have need for food insecurity, housing insecurity, things like that. And the goal of the model is to reduce disparities in access and treatment. The model aims to improve outcomes and experiences for mothers and their newborns. Specific outcomes, what we're talking about here, could include fewer C-sections, shorter hospital stays, lower postpartum anxiety, and better high-risk management of your higher-risk pregnancy patients. So MTM's approach to this is a two-tiered approach. So on the left side here, you'll see the non-clinical aspect. These are trained clinical healthcare or community healthcare workers. They're non-clinical education, benefit navigation, and social needs support. So anything that doesn't require a clinical aspect, but that can help to enhance the member's experience during this time. On the right side of that, you'll see our tier 2, our clinical base. This is our community paramedicine. So this is clinical care specifically by trained paramedics and EMTs in the communities that can be used for things like vitals, monitoring, telemetry, and coordinating with healthcare providers. These are all tailored for specific maternal and infant needs. And on the right, you'll kind of see the process of this, of how this works through. If we receive a referral, we reach out to the member. We determine whether this is community health or paramedicine, clinical or non-clinical. What is their specific needs? Sometimes they need both. An ongoing intervention by MTM Health in accordance with the care plan. That can be in coordination with social work, that can be in coordination with their primary care, the OBGYNs, or even the healthcare case managers. Our care plan is updated by case management, and the assessment is shared back to the referring team. So there's constant communication and documentation involved with this. So aligning with the particular maternal health model, when we look at this and how it aligns with what we're already doing in the space, MTM's extensive experience working with TMS to implement innovative care models and our ability to lead this program, and if they are in one of the awarded states, for the 15 states that were selected this year for the funding, we've been doing extensive work with Medicaid members on this very topic. So maternal and health, and our team has spent the last decade implementing CMS programs. So we have very relevant experience in this space. As part of a follow-up discussion with your individual plans, we can share very specific data and outcomes. As we've been working through this, we've been able to really compile some very interesting and helpful data that we're happy to share as you're looking towards developing your goals and your scope of work going forward. Appears to be a very long development period for this program, but as part of the MTM's MIH program, we have the expertise and resourcing already in place to be able to kick off immediately and be your partner to work with CMMI and deliver these services to your most at-risk members. So applications of the community health workers, when we talk about the specifics of the non-clinical versus the clinical, for the community health workers, we take a whole person approach to pregnancy, childbirth, and postpartum care, addressing the physical, mental, and social needs experienced during pregnancy. We know that can be very wide-ranging. So what does that actually look like? Our fully trained and certified community health workers provide services such as screening and assessment. So one of the things we specialize in is locating hard-to-reach members. Because we are located in the communities, we have had extremely good luck with reaching members that maybe the health plans have not been able to locate, because we use local resources. Sometimes we're better able to find transient members, people that are living in unhoused situations, and been able to make contact when a lot of other efforts have failed. So we're very proud of that. Home visits, we can do remote monitoring. Preventative care, we can help with scheduling and transportation. So if they don't know how to access their benefits, they don't understand their benefits, they need help scheduling for transportation, we can help with all of that. We can also do social service referrals for things like food insecurity, housing insecurity, domestic violence, a number of social issues that they may need assistance with. We do care coordination with primary care physicians, case managements, and specialists. When we talk about the application of the community pairs and the clinical side of our two-tiered approach, our network of EMS providers support maternal and infant health by providing accessible in-home healthcare checks and education in between doctor visits. So we're talking about additional outreach and services actually where the members are located, which makes it so much better for them to be able to get the care that they need. They play a vital role in healthcare deserts and can help close care gaps, specifically in rural and underserved areas where services may be lacking. So for members who have to travel particularly far, they have trouble coordinating their healthcare with their work schedule and things, this helps to fill that gap to make sure that they're still getting the care they need, even if they are not immediately accessible to their primary care physicians. Key ways that we can help with maternal and infant health as paramedics, completing prenatal care checks and conducting regular home visits to monitor vital signs, assess fetal well-being, address concerns between the regular prenatal appointments. We provide postpartum support, checking on new mothers, monitoring infant growth and development, providing clinical advice and support after delivery. And we can assist with identifying risk factors and potential issues like gestational diabetes, postpartum depression and psychosis through regular assessments, and then working with the CHWs to refer mothers to community services for food assistance, mental health support, transportation needs, other various things. So providing early intervention and promptly responding to potential complications during pregnancy or postpartum, and facilitating timely access to appropriate medical care helps to build trust by establishing a trusting relationship with the mothers through regular home visits, meeting them where they are in a comfortable environment, allowing for open communication to discuss and address concerns. And as a longtime paramedic, I can tell you the patients will tell you far more and show you far more in their own home where they feel comfortable than a lot of times when they will in a healthcare setting. Benefits of community paramedicine for maternal infant health include early detection and management of potential issues, changing patient status for better health for mothers and babies that leads to improved health outcomes, increased access to healthcare for underserved populations, potentially narrowing healthcare gaps leads to reduced disparities, especially in healthcare deserts, and helps prevent unnecessary emergency room visits by addressing issues early on, leads to more cost-effective care by making sure they get to the right care, right level of care at the right time. And with that, I'm going to kick it back to Julie.
Actually, she's going to kick it back to Tracy. While Colleen loves giving all the details of what we can do, I have the honor and privilege of giving the details of what we have done. And as they say, the proof is in the pudding, AKA our data. Our community health workers provide results. As you can see in this slide, they do great work. They did reach out to our members and provided pregnancy screens. And in 30 days, our community health workers worked with over 350 members to schedule or get attended postpartum visits. This is fantastic results. I'm going to share with you some other results that we are able to provide. We did a social needs screening and intervention. We were able to contact over 70% of members. This is worth noting because these members were referred to us, designated as UTC, unable to contact. So these were members that were specifically identified as being unresponsive to the health plan's attempts at phone outreach. With those screenings, we also identified interventions and provided both the screening and the intervention. As you know, our extensive, or as you may not know, our extensive network of community-based organizations and our added benefit of having local first responders on our team, we ensure the member receives food and housing as needed and transportation. You guys know transportation is our bread and butter. So we definitely have networks in place to close those transportation needs. Moving on, we did well child visits in the first 30 months of life. This was defined as the percentage of members who had both 6 or more well child visits in the first 15 months and 2 or more well child visits in the following 15 to 30 months. Relating to this measure, our community health works completed over 370 encounters with 220 children, in which we not only assisted with getting the screenings completed and their well visits completed, but provided end-to-end care that started with the screenings, the needs intervention, solved screening, resolved SDOH challenges, and ensured that these critical well child visits were completed for our members. That being said, those are just some of the successful stories that we can tell about our mobile integrated health solutions. And I will turn it over to Julie to close us out. Julie?
Awesome. Thank you so much, Tracy and Colleen, for that detailed overview. That was great. We know that transportation barriers can have a major impact on the outcome of maternal and infant health, as you just heard. And until those barriers are addressed, as we've talked about, Both the mother and the baby face numerous short-term and long-term risks. The work that we're doing here at MTM Health is really aimed at preventing those missed appointments, improving health outcomes, and closing those gaps in care. Making sure all babies and their mothers have a strong and healthy start is really the best way we can reverse those global stats and start seeing a decline in the maternal infant health mortality rates. So we've included a QR code on how to get more information. So you can just take a snap of that from MTM Health and how we can support your health plan. And like I said at the beginning, we were going to save some time for some questions that came in. So we have some. Let me pull these up. Do care coordinators and drivers receive training to handle sensitive maternal health needs? Tracy, I'm going to hand that one over to you.
Thank you. I'm having trouble with my camera. Sorry about that.
No worries.
So yes, and the answer is yes, with some caveats. So our care coordinators do receive special training on how to deal with specific maternal health issues that they may encounter. In our pilot in Ohio, both the care coordinators and the drivers will receive special training. And our Vail Ride drivers, if you were to choose option 1, our Vail Ride drivers receive additional healthcare training when they are onboarded. For Lyft and Uber, or for our Lyft Flex option, that would be specific to Lyft and is not provided. They're not provided that specific maternal health training that we would love to see everyone get. So I'll turn it back over to you, Julie. And I'm going to leave my camera on so I don't have so much trouble.
Okay, oh, here's another one. Hello, thank you for this wonderful webinar. I am a transportation provider currently serving Inland Empire here in California. How can we join your team of great transportation providers here in California and Arizona? We can definitely get you the contact for that offline. So we will reach out to you offline to do that. So thank you. Another question, are there any pilot programs or partnerships in the state of Tennessee for your transportation pilot programs for maternity members and infants? Colleen, is there any that you're aware of, or
there's not currently, but we would love to have one. So if you and your plan are interested in setting up a pilot program, we would be delighted to speak to you. We're really excited with the pilots that we're doing so far, and we would definitely love to expand on those.
Awesome, great. For the next one, for members in Medicaid MCOs, how do MTM CWHs relate to and communicate with MCOs, CHWs, and care coordinators and avoid duplication of services?
You want me to take this one?
Yeah, if you could.
Okay. All right. So we have a software platform called Gelada that we can use that would communicate directly with your case managers and CHWs. So you would view this as an extension of your available network of CHWs. So as you set up care plans or have orders or things like that that you would like done in the home, we communicate through that Gelada platform. It's a really great software system for this communication documentation. It also allows you to pull a variety of reports, see in real time what's going on with the patients in the home. So to avoid the duplication, of course, we would have the plans that have CHWs in place. View this as an extension of your service. Utilize our CHWs to help extend your reach into the home and to make sure that if you're trying to make HEDIS measures, if you're trying to address vaccinations, if you're trying to address any specific sort of metric, that our crew is working in conjunction with your CHWs and caseworkers to meet your goals and your metrics. Hope that answers your question.
All right, awesome. And then I think we have a similar question for Medicaid MCO in Texas. I think this is related to the pilot question that we had a minute ago. Do we have any pilots in Texas right now?
Not currently, but we're open.
Okay.
And we are talking to some of our MCOs in Texas about what we can do, but currently nothing in place.
Okay. Thank you. Our next one, do you integrate with the health system, health plan, or OB provider EHR to communicate and or coordinate care? I'm assuming this is for the MIH. Colleen, are you familiar?
So currently we don't have one that's, we haven't had that set up requested specifically. That's something that we definitely be open to. So if they're using Epic or they're using any of the additional ECWs that are out there, we do have the ability to integrate with some of those. Again, we do have the Gelada software and platform as well that we can use for communication back and forth. So if their particular ECW doesn't allow for an API or integration, we can also give access to healthcare providers to log into the Gelada platform to be able to see the clinical notes as well.
Great, thank you. And then thank you for this. We have piloted MIH with local ambulance districts here in Missouri. Can you speak to your data systems and how to capture information or share it with the health plan?
Again, similarly there, that Gelada software platform is available and would work both ways back and forth. Of course, we also have, through our MTM systems dashboards for the transportation portion of that are client accessible as well, so that you can also track members through that for just your transportation needs. So we do have a variety of systems to be able to work directly with the healthcare providers, the paramedicine crews, as well as the health plan to monitor all aspects of the patient care and transport.
So thank you. And I think this one goes to you as well. Colleen, please, could you speak to how you partner with providers, particularly providers in rural locations? To what extent are they involved and how are high-risk maternal patients being managed?
Tracy wants this one.
Yeah, I'll definitely take the first question and then I'll defer to Colleen if she wants to take the second one, or I can take both. But we absolutely love our rural partners. And some of the things that we have done at MTM to support them, we have dedicated vendor account managers. We call them our VAMs, and they are assigned a transportation provider partner. So any transportation provider we have is assigned a VAM. That VAM works with that provider. They provide them support if they have questions about policies, processes, predicaments, payments. They have a dedicated person that they can reach out with and collaborate with to find the solution, or answer to that. Additionally, our VAMs will communicate with our rural transportation providers to identify any opportunities that they have. If we are experiencing gaps in any of our rural communities, these VAMs that have those relationships will reach out and say, here's what we're seeing. How are you able to help us? How are you able to assist us? How are we able to partner with you to service these members? And really provide that collaboration that helps develop and bridge those rural community transportation gaps. In addition to that, we work very diligently to schedule in advance those rural areas where transportation is limited. So advanced scheduling will help those transportation providers in that rural atmosphere. And then we also have what we talked about earlier, our VEO ride. That is scalable. It's implemented very quickly in areas where we are seeing challenges, which can impact our rural communities. And Colleen, did you want to answer that high risk, or would you like me to go ahead?
No,
Okay.
I'm happy to. So when you think about high-risk maternal patients, you're probably thinking about patients that need, frequent vital sign monitoring. Maybe they're developing some hypertension or they have a history of preeclampsia, things like that. So we can, from a clinical aspect, be monitoring those patients. Gestational diabetes, members that may be developing that during the pregnancy, need blood sugar monitoring, maybe need some education. So those can also be managed in educated in the home as well, and in conjunction with healthcare providers. And then, of course, under the direction of medical control, talking about patients maybe suffering from hyperemesis and maybe need to have that cared for in the home, IV fluids, rehydration, antiemetics, things like that. I mean, how many patients could you keep out of the ER if you could help manage some of these conditions at home with frequent visits and their own individual healthcare attention where they're at. So there's quite a wide variety of things for managing a high-risk patient that can be done in the home in conjunction with their primary care, their OBGYN, and under the medical control direction of the local EMS system for paramedics.
Awesome, thank you. One other one, what has been particularly successful in your model for contacting those who are typically unable to reach, and are your referrals coming solely from the health plan?
You want that, Tracy, or?
I'll tell you what, if you want it, you can have it. If not, I'll take it.
Okay, sure. So I think one of the things that makes us most successful when we're reaching the hard to reach patients is because we're using local resources, community health workers, local EMS, social service agencies that are already located in the communities. First of all, members tend to trust them a little bit more. So they're more apt to answer the phone. They're more apt to come to the door versus a phone call from a health plan or somebody they don't know, an unknown number, things like that. So we also have had great success with using local EMS that knows where our transient folks maybe are more likely to be located. They know where to find them when it's mealtime at local food resources, things like that. So we've really been able to leverage that local knowledge and real understanding the communities to be able to locate folks that maybe are a little bit outside the box from what the standard email, phone, text messages that we may, pretty accustomed to using on a regular basis. Right now, our referrals are coming from the health plan, but they don't have to just come from the health plan. And health plans working with hospitals as well can help to identify some of their highest ER utilizers. One of the programs before I joined MTM that we worked with most closely was an ACO that I just pulled a list of their highest ER utilizers, and that was the population that we targeted. So, we suggest as well that if your plan is interested in developing a program like this, that maybe you work in conjunction with some of your local hospitals to help identify patients that might benefit from this as well, outside of maternal health. But they're also going to know who your biggest maternal health risks might be, what we lovingly call in the EMS world frequent flyers, the folks that need the most outreach and the most care and support. So we would definitely suggest a team model in securing our referrals for these programs.
Awesome, thank you. Go ahead.
Thanks, Julie. In our Ohio program, the health plan actually reached out to two local healthcare providers that are supporting that identified population to see if they could also engage them in providing referrals. So while it is health plan driven, it is outside of the Ohio pilot does have referrals coming from outside of the health plan itself.
Great, thank you. Will we share our slides? Yes, absolutely. We'll get those out after the webinar is over. And then I realize this presentation has been focused on transportation for maternal health. Has MTM explored or considered something similar for behavioral health population? Transportation is a huge barrier in that population as well. And yes, this is an awesome question and 100% agree. And Tracy, I know this is one of your big passions as well, that we're working on doing a pilot in the Ohio market for behavioral health as well.
Yes, so yeah, this presentation was focused on maternal health, but MTM is very close to behavioral health and is working in several different and in locations to pilot some behavioral health projects. We in Ohio have worked with the State of Ohio Association for Transportation, Ambulance and Medical Transportation, and we came up with a basically a white paper regarding secure transportation to move transportation out of the ambulance where a patient has to be secured via the hot straps in an ambulance, put on the cot, secured, put in the ambulance, which can be demoralizing and can escalate a behavioral health member's anxiety in acute situations. And looking at a different type of transportation where they're put in a secure vehicle where they can't undo their buckles and jump out of the back of an ambulance as they're driving down the highway. Instead, putting them in a sedan or SUV where the doors are secured, they're not able to exit while the vehicle is in motion. And there are cameras in the vehicle to ensure that this vulnerable population is safe. And we are working on that. We have finished the paper. We are now presenting to the MCOs to get their buy-in. And then we already worked with the Ambulance and Medical Transportation Association in addition to the state, and have received their blessing for this pilot or the program.
Yeah, thank you. But agreed, that is such a huge concern as well. Behavioral health is just something we were also very focused on. Another question, are MTM paramedics reimbursed by MCOs as Medicaid providers through claims or through other payment arrangements?
So Julie, do you have a business model already set for this, or?
Pardon me?
For business development of this, do we have like something to share on this particular, how the different payment arrangements we might have or different programs we might have?
Yeah, maybe we'll follow up on that specific question. Okay. And then I have another one. Can you give us a little more information on the TMaH model and how it was designed? Yes, I can do that. So this is the Transforming Mental Health or Maternal Health is the newest CMS model. It was designed to focus exclusively on improving maternal health for women enrolled in Medicaid and CHIP. The model was just launched on January 1st in 2025, and it's going to run for 10 years. And there's currently 15 states that are participating in it. And it's really designed to support those participating states in the development of a whole person approach that kind of Colleen had walked through in regard to pregnancy, childbirth, and that postpartum care. They'll be working with the states to get activities and access to things such as midwives, doulas, improving that prenatal care for the chronic conditions that some of the moms have, like diabetes and hypertension. So it'll be interesting to see as some of the results start coming in for these 15 states, how impactful that is, and how we can see some significant changes to, some of the maternal health issues that we're seeing today. So right now, those are the only questions we had open. Thank you all so much for the participation and the great questions. As we mentioned, we will definitely get the slides out to you all. If you have questions, feel free to reach us offline and we'll get answers back to you. But thank you so much for joining us today for this really significant topic that is just so timely for our country right now. Have a great rest of your day.